everybody, and welcome to the Lipids lecture series. Um, this lecture was originally prepared by the laboratory core staff at Valley Health Hospital for the Medical Laboratory Science program at Valley Health, and it was updated this year by myself, Carolina Vilches. And all of the information that you need for this particular lecture series is found in chapter 15 of your chemistry book by Bishop. So let's start talking about the lipids and lipoproteins. As you may already know, lipoproteins and lipids are central to the energy metabolism of the body, and they have become clinically significant because of their association with coronary heart disease. There is a very clear link between blood lipid levels and the development of atherosclerosis. Accurate measurement of various lipids and lipoproteins is very important in the diagnosis and treatment of patients with dyslipidemia. Guidelines have been developed for the detection and also the treatment of high cholesterol, and as well as for the performance goals of accuracy and precision for measurement of lipids and lipoprotein analytes in the laboratory. Um, Lipids are a class of compounds that are soluble in organic solvents and insoluble in water. Chemically, they are a compound that yield fatty acids on hydrolysis, or complex alcohols that combine with fatty acids to form esters. Um, they have a very important role in our body, and they have many different functions. They function as hormone precursors or hormones. Lipids aid in the digestion. They provide energy storage and metabolic fuels. They are functional, and they're part of the functional and structural components in biomembranes of the cells, and they help with insulation for nerve conduction and prevent the loss of heat. This slide shows you more of the lipid functions that I just talked about. So they function, or one of their roles is to be structural components of biological membranes. So cholesterols, phospholipids, and glycolipids form and maintain intracellular structures as your lipid membrane bilayers. Lipids also serve as energy reserves. They provide twice as much energy as carbohydrates do. They also function as hormones and vitamins, such as steroids, and lipophilic bile acids, as lipids are important for lipid solubilization. Lipids are classified in these different ways. Lipids can be sterol derivatives, fatty acids, cholesterol esters, sphingomyelin derivatives, or terpenes, or isoprene polymers or vitamins. So the sterol derivatives are mainly cholesterol and cholesterol esters, steroid hormones such as testosterone and estradiol. They can be bile acids in vitamin D. Fatty acids can be short, medium, and long chain fatty acids. Prostaglandins are also part of the fatty acids classifications. Cholesterol esters are acetylglycerols and phosphoglycerides. Sphingomyelin derivatives are sphingomyelin and glycosphingolipids, and the terpenes or the isoprene polymers are vitamin A, vitamin E, and vitamin K. Sterol derivatives are cholesterol strain structures. Cholesterol is a steroid alcohol that has 27 carbon atoms that are arranged in a strain skeleton. The numbering system of the carbon atoms is important because they represent the initial starting point for other metabolic pathways, and that includes the formation of vitamin D, steroid hormones, and bile acids. Basically, cholesterol is found in all of the animal products and also found in some plants. Some of the sources of cholesterol include meats, egg yolk, seafood, whole fat dairy products, olives, coconuts, avocados, and nuts. The American diet contains about 300 milligrams of cholesterol each day. And this is the main structure of cholesterol and the main function. Cholesterol, it is an unsaturated steroid alcohol that contains 4 rings: the A ring, the B ring, the C ring, and the D ring. And it has a single CH side chain tail that is very similar to a fatty acid. So it has 4 fused rings as the core, and it is shared by all steroids. It has a membrane component, and it is a precursor to bile acids, vitamin D, and steroid hormones. Here is an example of the dietary sources of cholesterol, and the type of fat that it is linked to. So monounsaturated fats can come from olives, olive oil, canola oil, peanut oil, cashews, almonds, peanuts, and most of the other nuts, also avocados. Polyunsaturated fats can come from corn, soybean, safflower, or cottonseed oil, and fish. Saturated fats can come from whole milk, butter, cheese, and ice cream, red meat, chocolate, coconuts, coconut milk, coconut oil, egg yolk, and chicken skin. And trans fats come from most margarines. For example, vegetable shortening, partially hydrogenated vegetable oil, deep fried chips, many fast foods, most commercial baked foods. And on the right side of this particular table, you'll see what the effect is of this particular type of fat on the cholesterol level. So a high intake of monounsaturated fats can lower the LDL, which I'll explain what that is a little later, and raise the HDL, which is known as the good cholesterol. The polyunsaturated fats can lower LDL and raise HDL. Saturated fats can raise both LDL and HDL, and trans fats can raise LDL. So, dietary fats are basically emulsified by bile salts in the intestine, and it's very, very important to know how these fats are absorbed by the gut in the body, or how they are processed. So the exogenous and the endogenous pathway, which I'll talk about in the next slide, are pathways of lipid absorption that depend on an ApoB containing lipoprotein particles that can be viewed as the process to transport dietary lipid and hepatic-derived lipids to the peripheral cells. Basically, the pathogenesis of atherosclerosis comes from the net results of these pathways, which is to deliver or to forward the transport of cholesterol to the peripheral cells. Atherosclerosis results when the cells in the vessel walls accumulate too much cholesterol. Peripheral cells are prone to accumulating cholesterol because they also synthesize their own cholesterol. And unlike liver cells, they do not have a good mechanism or they don't have the enzymatic pathway to break down cholesterol. So that's how the accumulation of cholesterol occurs in the vessel walls. So in the exogenous pathway of digestion and absorption of fats, it's important to know that dietary fats are first emulsified by bile salts in the intestine. An enzyme called lipase, it hydrolyzes triglycerides into monoglycerides and fatty acids. cholesterol esterases hydrolyze cholesterol into free cholesterol and fatty acids. Fatty acids then attach to albumin and they travel to the liver, but free cholesterol and monoglycerides are absorbed into the intestinal mucosa where they combine with phospholipids to form chylomicrons, which then travel into the bloodstream. Lipoprotein lipase is another enzyme that breaks down the chylomicron and allows the fatty acids to be used for energy by the muscles or taken up in adipose tissue for storage. Free cholesterol is converted to bile acids, is used as a precursor for other products, or it regulates the amount of cholesterol that is taken in by the cells. In the endogenous pathway, the body synthesizes 1 gram of cholesterol each day in the liver, intestinal wall, and minor amounts in other areas of the body. So cholesterol is synthesized through a series of enzymes that begin with acetyl coenzyme A. The amount of cholesterol that is made is regulated by an enzyme called the HMG coenzyme A reductase, and it's regulated by a feedback mechanism. The hormones thyroxine and cortisol actually help rise or lower the enzyme's activity. So in this slide, you can see a picture that depicts the cholesterol synthesis pathway. So cholesterol is created from acetyl coenzyme A. The rate-limiting and irreversible step in this pathway is actually the conversion of the HMG coenzyme A to mevalonate. The HMG coenzyme reductase is the enzyme that is responsible for this particular step. And when most drugs that are used with treating cholesterol or conditions, they target high plasma cholesterol in this particular step. So vitamin D, a small amount of cholesterol can also be transported to vitamin D in the skin, transformed into vitamin D in the skin by irradiation from sunlight. So the 7-dehydrocholesterol in the skin is converted to cholecalciferol, which is vitamin D3, by UVB rays of the sun. In the liver, 25-hydrolase, which is an enzyme, it converts cholecalciferol into 25-dihydroxyl vitamin D3, also known as 25-OH vitamin D. In the kidney, 25-OH vitamin D is converted by the enzyme 1-alpha hydrolase into 1,25-OH2 vitamin D, which is an active metabolite. And over here in the right, you see that about 80 to 100% of vitamin D is gotten through casual exposure to the sunlight. Sunlight is absorbed through the human skin. And then you see the following step in terms of cholecalciferol or vitamin 3D being converted into 25-dihydroxyvitamin D3 and then into 125-dihydroxyvitamin D3. Here is a slide that shows you the vitamin D sources and functions. Ergocalciferol is vitamin D2 that is the type of vitamin or the type of D vitamin that most of the supplements contain. At Valley Health Hospital, in the laboratory, we measure 25-OH vitamin D on one of the main chemistry instruments, which is the Centaur. There are 3 ways to get vitamin D. There is no recommended daily amount, but 200 international units of vitamin D up to the age of 50 are considered adequate. So you can get vitamin D from sun exposure. about 10 to 15 minutes twice a week to the face, hands, and back without sunscreen for sunlight. You can also get vitamin D from supplements, which most of the supplements contain vitamin D2, but vitamin D3 is far way more potent. And also from foods, so oily fish such as salmon and tuna. There are also vitamin D fortified foods and drinks that a person can take. And on the right, you see the cycle of vitamin D and how it is processed in the body and how it is used and its function in the body. Okay, so next we are going to talk about fatty acids. The general chemical formula is the RCOOH. The R is an alkyl chain, and the COH is the carboxyl group. Fatty acids are triacylglycerols that are hydrolyzed to glycerol, and 3 fatty acid chains of general structure RCOOH. Saturated fatty acids have no double bonds in their long hydrocarbon chains, and unsaturated fatty acids have one or more double bonds in their hydrocarbon chains. As the number of double bonds in the fatty acid increases, the melting point decreases. Fatty acids are classified by the number of carbon atoms in their chains. So short chains have less than 6 fatty acids, carbon atoms. Medium chains have between 6 and 10, and long chains between 12 and 26. Fatty acids are also classified by the degree of saturation. Saturated fatty acids have no double bonds. Monounsaturated have one double bond, and polyunsaturated have more than one double bond. The melting point of a saturated fatty acid is higher than an unsaturated fatty acid with the same number of carbon atoms. The double bonds lower the melting point. The greater number of double bonds, the more liquid it is at room temperature. Saturated fatty acids have no double bonds in their carbon chains. The chains rotate freely. Monounsaturated again have one double bond, which is fixed at a 30-degree bend. Polyunsaturated have multiple bonds, or multiple bonds, 3 carbon atoms apart on the chain. The body breaks down fatty acids by doing the beta oxidation, which shortens the chain by 2 carbon atoms at a time. Fatty acids are converted to acetyl coenzyme A for energy in the cells. Trans fatty acids in our diet are manufactured by chemically reducing the double bonds to raise their melting point. An example is hardened margarine. So most fats in the body are derived from the diet. The body is able to synthesize most fatty acids except for 2, linoleic acid and linolenic, which are essential for good health, growth, and development. These essential fatty acids must be consumed in foods or taken as a supplement. So essential means that these substances cannot be made in the body, so they must be gained from food sources. So the two main types of essential fatty acids, EFA, are again polyunsaturated fatty acids. And the EFAs are needed for the maintenance of cell membranes, hormones like substances called echinosoids or prostaglandins, which are involved in clotting of the blood. And I think you guys remember that from your coagulation lecture. And on the right, you see a table that explains the omega-6 family and the omega-3 family. The omega-6, which is the linoleic acid, or LA, which is found in vegetable oils, seeds, and nuts. And the omega-3 family, which is the alpha linolenic acid, the LNA, which is found in green leafy vegetables, flaxseed oil, canola oil, walnuts, and Brazil nuts. And then you in this slide also see the pathway of conversion of the two different types of omega families or fatty acids. Prostaglandins are a bioactive lipid that exert diverse physiological action at concentration as low as 1. They are synthesized at the site of action and are made in almost all of the tissues. Prostaglandins are unsaturated 20-carbon fatty acids. They are involved in inflammation. Prostaglandin EI and prostaglandin E2 induce the symptoms of inflammation such as redness and swelling, edema, etc. due to arterial vasodilation. Prostaglandins are neutral mediators of inflammatory reactions of rheumatoid arthritis, psoriasis, and conjunctivitis. Corticosteroids are used to treat these inflammatory reactions since they inhibit prostaglandin synthesis. Next is glycerol esters. Glycerol is a 3-carbon alcohol that contains a hydroxyl group on each of its carbon atoms. It is chemically possible to sterify each hydroxyl group with a fatty acid. They are classified by the number of fatty acids that they contain. So they can be monoglyceride, diglycerides, and triglycerides. So this is the way that triglycerides are formed. You can take one glycerol molecule and 3 fatty acid molecules, and one water is removed for each fatty acid that is joined to a glycerol. When this is done, the result is fat. The endogenous pathway synthesis of triglycerides explains how triglycerides are synthesized. Triglycerides are synthesized predominantly in the liver and the adipose tissue. Acetyl coenzyme A units condense to form fatty acids. Glycerol and 3 fatty acids form triglycerides. Synthesis is promoted by factors such as increased levels of fatty acids, insulin, and ethanol. And in the liver, triglycerides are incorporated with cholesterol, phospholipids, and apoproteins to produce VLDL particle. Phosphoglycerides, single-side derivatives, and terpenes. Phosphoglycerides are lipids with a glycerol backbone that contain phosphorus and are found in cell membranes. Sphingosine is an 18-carbon alcohol which is used as a precursor to form gangliosides, which are abundant in gray matter of the brain, and glycosphingolipids, which are a source of blood group and tumor antigens. Terpenes are polymers of the 5-carbon isoprene unit and include vitamins A, E, and K. Okay, so now we are going to move on to talk about lipoproteins and how we measure these in the laboratory. Lipoproteins are lipid protein complexes in which lipids are transported into the blood. Lipoprotein particles are spherical with a non-polar neutral lipid of triglycerides and cholesterol esters in their core. On the surface are polar lipids of phospholipids and free cholesterol. Also on the surface are apolipoproteins. Lipids are not soluble in water and must be transported in the bloodstream attached to a protein. And this is an example of a lipoprotein particle. And the main role of lipoproteins is really the delivery of fuel to peripheral cells. Again, it is a spherical molecule and they range in size. A lipoprotein particle is composed of lipids and proteins, and that's why it is called lipoprotein. lipoproteins. And amphihepatic cholesterol and phospholipid molecules are primarily found on the surface of the lipoproteins as a single monolayer, whereas the hydrophobic and neutral triglycerides and cholesterol ester molecules are found in the central or the core region of the lipoprotein. And there are different classifications for lipoproteins, and these are chylomicrons, VLDL, IDL, LDL, and HDL, and we'll go over each one of these. Chylomicrons are produced by the intestines, where they are packaged with absorbed dietary lipids and apolipoproteins. The principal role of chylomicrons is the delivery of dietary lipids to the hepatic, to the liver, and to the peripheral cells. Chylomicrons are the largest and lightest of the lipoproteins. Exogenous triglycerides come from the diet. They have a lipid to protein ratio of 99:1. They cause blood samples to be lipemic, and they could look cloudy, milky, or turbid. They stay at origin when electrophoresis is done, so it doesn't migrate very far. It is measured as triglycerides in the blood, chylomicrons. VLDL stands for very low density lipoprotein. It is produced primarily by the liver and contains ApoB100, ApoE, and ApoC. It is rich in triglycerides. It is a major carrier of endogenous triglycerides and transfer triglycerides from the liver to the peripheral tissue, mostly during a fasting state for energy. The triglycerides are measured again in the fasting blood specimen. In electrophoresis, it migrates to the pre-beta position. And VLDL is the type of lipoprotein that causes plaque in arteries. IDL stands for intermediate density lipoprotein. It is a smaller and more dense molecule than VLDL. Endogenous triglyceride and cholesterol esters are part of IDLs. It has a lipid to protein ratio of 85:15. It is formed as the VLDL particle loses triglycerides in the bloodstream, and in electrophoresis, it migrates between the beta and the pre-beta position. LDL is low density lipoprotein. It's smaller and denser than IDL. It is formed or composed of cholesterol esters. The lipid to protein ratio is about 80:20. It represents about 70% of the total cholesterol in the body. It's formed in the liver, and during electrophoresis, it migrates to the beta position. So again, LDL, or low density lipoprotein, is very rich in cholesterol. It forms as a consequence of the lipolysis of VLDL. It is readily taken up by cells via the LDL receptor in the liver and peripheral cells. LDL particles have the ability to infiltrate into the extracellular space of the vessel wall, where they can be oxidized and taken up by macrophages. HDL is the high-density lipoprotein. It is the smallest and most dense. It is synthesized by both the liver and the intestine. It can exist as either a discoid-shaped particle or more commonly a spherical particle. HDL has the ability to remove cholesterol from cells, and it does this by a process called the reverse cholesterol transport. This is one of the main mechanisms that is proposed to explain the anti-atherogenic property of HDL. HDL is also called the good cholesterol, so it is it is known to reduce the amount of bad cholesterol in the body. Again, it is formed in the liver. It has a lipid to protein ratio of 50-50, and during electrophoresis, it migrates to the alpha position, and it removes cholesterol from the bloodstream. So the main way the peripheral cells maintain their cholesterol equilibrium is by or is through the reverse cholesterol transport pathway, which is mediated by the HDL. The high density lipoprotein. Excess cholesterol from peripheral cells is transported back to the liver, where it can be excreted into the bile as free cholesterol or after being converted to bile acids. Excuse me. The liver helps the body maintain cholesterol homeostasis. So cholesterol can only be excreted from the body through the liver. HDL absorbs the free cholesterol from the peripheral cells and macrophages and transports it to the liver. In HDL, LCAT sterifies the cholesterol, which prevents it from re-entering the cells, and cholesterol can be excreted through the feces or through metabolized into bile acids. This table right here is really nice because it shows you the different types of lipoproteins that we just discussed, where it's made, the main component in terms of lipids and proteins, and their main function. So chylomicrons are made in the small intestine. Triglycerides are the main components of chylomicrons, but also they have some cholesterol and fat-soluble vitamins. Their main function is to deliver dietary fat from small intestine into the cells, bring dietary cholesterol to the liver. VLDL, very low density lipoprotein cholesterol, is made in the liver. The main component is triglyceride and also a little bit of cholesterol, and it transports lipids from the liver to the cells. LDL cholesterol, or the bad cholesterol, is also known as the remnant of VLDL that forms in the blood as VLDL loses its triglyceride content. So it is made mostly of cholesterol, but it does have a little bit of triglyceride component. Its main function is to transport cholesterol, dietary and cholesterol made in the body, into the cells. HDL cholesterol, which is the good cholesterol, is made mostly in the liver. We also make some in the small intestine. It has mostly protein, and it is a cholesterol scavenger that picks up cholesterol from cells and tissue and brings the cholesterol back to the liver so that it can eventually be excreted from the body. This table right here is really nice as well because it shows you the lipoprotein size and composition and the differences in their sizes or in their particle diameters. And this is measured in nanometers. And also it shows you the ratio of lipids, of total lipid percent to total protein percent in each one of these different lipoprotein molecules. So you see that HDL has about 50% total lipids and 50% total proteins. LDL has more of total lipids and less total proteins. IDL, which is intermediate density lipoprotein, has 85% total lipids and 15% total proteins. VLDL, it's 92% total lipids and 8% total proteins, and chylomicrons are the largest of these particles, have 99% of total protein and about 1% of 99% of total lipids and about 1% of total proteins. And that's the difference in the diameter between these different lipoproteins. And this image right here shows you the life cycle of cholesterol carrying lipoproteins and how they are processed through the liver into the body. Lipoprotein lipoprotein can be determined by electrophoretic or electrophoresis methods, and this can actually fractionate some lipoprotein subclasses to characterize the more atherogenic fractions. So you can also take a look at what are the bigger lipolipids versus the larger or lighter subclasses of lipolipids. So as you can see, you have the different lipoproteins and the different electrophoresis reactions in agarose gel. So you have HDL, you have the VLDL, the LDL, which is in the beta, it travels or migrates into the beta position, and the chylomicrons. And again, this picture shows basically the same thing, the electrophoretic pattern of serum lipoproteins. You have the origin, you have the beta position, the pre-beta position, and the alpha position, and where they usually, these different lipoproteins tend to travel. And you'll see that the LDLs in the beta position, VLDLs in the pre-beta, and the HDLs in the alpha position. The beta position is closer to the origin of the electrophoresis. And on the right, you see the different reactions. For example, different a normal reaction for chylomicrons in terms of how it travels between the beta, the pre-beta, and the alpha migration. So this table right here shows you some lipoprotein disorders um, that we should be familiar with. So type 1 is called, or type 1 lipoprotein disorder is also called hyperchylomicronemia. And the defect here is a low LDL with an altered APOC2. What you will see here in the serum is an increase in chylomicrons. The clinical features include pancreatitis, lipemia, retinalis, skin eruptions, xanthoma, hepatosplenomegaly. The treatment for this familial hyperchylomicronemia is actually diet and making some diet restrictions or making some lifestyle changes. And the appearance of the serum could look creamy in the top layer. Type 2A is familiar hypercholesterolemia, in which the defect here is a decrease in the LDL receptor. So what you see in the serum is an increase in LDL, thalassemia, arcusitis, and tendon xanthomas are associated with an increase in LDL. The treatment is the cholestyramine or cholestyramine for the most part, and niacin, and you really don't see anything in the serum appearance. Type 2B is combined, familial combined hypercholesterolemia, in which you will see an increase in LDL and also an increase in VLDL. There is also type 3, which is familial beta lipoproteinemia, in which you will see an increased intermediate or IDL. And here the defect is a synthesis defect of the ApoE2 protein. And what you see in the sample is a turbid solution. Type 4 is familiar hyperlipidemia. You'll see an increase in VLDL. It is treated with statins, niacin, or fibrate. And type 5 is endogenous hypertriglyceridemia. And what you see is an increase in VLDLs and also in chylomicrons. And the serum would look a bit creamy, probably on the top layer, and perhaps turbid in the bottom of the tube. Okay, so atherosclerosis is actually the single leading cause of death in in America and also in some developing countries. So it is very, very important that uh, that we determine what is the association of lipoproteins and lipids to cardiovascular disease. So advances in technology and advances in the diagnosis or um, um, has really made it a little bit better in terms of the diagnosis and the treatment of lipid and lipoprotein disorders. Um, Also, life changes and adjustments are very, very important, and they're taken into consideration in the treatment of lipid disorders. So, cholesterol guidelines have been made by many different associations, such as the American Heart Association, the American College of Cardiology, the National Cholesterol Education Program, heart.org or lipid.org, and all of these organizations have really contributed to creating guidelines for the prevention and treatment of elevated lipid panels and their association to heart disease. Um, excuse me. Um, the AP, ATP3 or the ATP stands for the Adult Treatment Panel. So ATP was founded initially in 1988 by the National Cholesterol Education Program. It was a program that has been responsible ever since for the publication of guidelines for physicians to treat patients with lipid disorders. So the National Cholesterol Education Program is responsible for educating not only physicians about this association with heart disease, but also for patients to know their condition and to manage their condition and to be aware of what's going on. So ATP1 was released in 1988 and then eventually was revised in 1993 as the ATP2, which involved moderate to high dose statin therapy to treat lipid disorders. But the ATP3 was founded in 2001, and the basis of it was to treat lipid disorders with high dose statin in combination therapy. The risk assessment for cardiac disease that is related to lipid conditions or lipid disorders really was based on a decision making by the physician, and based on this ATP3 classification protocol or classification of LDL, total cholesterol, and HDL cholesterol, and these are all by the milligrams per deciliter. So, for instance, if LDL cholesterol, which is really the primary target of therapy, was less than 100 milligrams per deciliter for one particular patient, that was the optimal or desirable cholesterol or LDL cholesterol range for the patient to be healthy. 100 to 194 was considered near optimal or above optimal. 130 to 159 is considered borderline high. 160 to 189 is considered high, and anything at 190 or greater than 190 was considered very high. So LDL cholesterol was really the primary target of therapy. We also take a look at total cholesterol and HDL cholesterol. It is desirable for a patient to be under 200 for the total cholesterol. Anything between 200 and 239 would be considered borderline high. And anything at 240 milligrams per deciliter or greater than 240 would consider high. HDL cholesterol, anything which is the good cholesterol, anything less than 40 is considered low, and anything greater than 60 is considered high. So you want the patient to be in between those two numbers. And so, what are some causes of elevated triglycerides? And this was released by the National Cholesterol Education Program for the ATP3 um, uh, guidelines or risk of triglycerides. And so several causes underline elevated triglycerides in the general population, and these include overweight, or a person being overweight or being obese, uh, physical inactivity. Cigarette smoking was another risk of elevated triglycerides, excess alcohol intake, very high carbohydrate diets, greater than 60% of energy. Other diseases that are involved, such as diabetes, renal failure, nephrosis, and also drugs, or the intake of drugs, would be related to the risk of high triglycerides, such as steroids, protease inhibitors, estrogens, etc., and some genetic factors. And here are guidelines that were adopted for lifestyle changes that are taken into consideration when treating patients um, um, with lipid disorders. And so it is implemented in a stepwise manner in terms of what the physician sees at every visit. So for example, with visit one, the physician will begin an evaluation with the patient by looking at the patient's weight and looking at ways to reduce the patient's weight. They would encourage the patient to increase their physical activity, or perhaps refer the patient to a nutritionist to talk about their diet in order to decrease their weight, their blood lipids, their blood pressure, and to improve their glucose levels. The norm is to visit the doctor about 6 weeks after that to check and see what's going on. And during visit two, the physician would evaluate the weight again, the weight control, levels of LDL, HDL, triglycerides, blood pressure, etc., and reinforce dietary changes, and also reinforce and encourage physical activity, and perhaps consider some meal replacements. 6 weeks after that, during visit three, the physician will evaluate again the same things as far as the weight control, LDL, HDL, triglycerides, blood pressure, glucose levels, and also really reinforce dietary changes and physical activity, because all of that has to be included into the treatment methods. If in either visit four, the physician sees that the weight has gone up, the lipid levels, the LDL, HDL, triglycerides, blood pressure is up, glucose levels are up, and there is no improvement of these parameters of metabolic syndrome, then the physician would consider some drug therapy for the patient. And that would be intensified by weight management and increased physical activity. So just because the patient will be put on medication, particularly statins, it doesn't mean that the patient will stop managing their weight or managing their physical activity. That is still very, very important. And then follow-up visits are important every 4 to 6 months to monitor the adherence to these triglyceride therapies if they have been indicated. So it is very important to take steps steps of therapeutic lifestyle changes into consideration in order to manage metabolic syndrome, or to manage or to improve the conditions of metabolic syndrome. ATP3 also states LDL cholesterol cutoffs for lifestyle interventions and drug therapy in different risk categories. So patients are put in different risk categories in terms, or depending on their LDL cholesterol goals or LDL cholesterol levels. And depending on that, a physician would initiate either therapeutic lifestyle changes or TLCs with drug therapy. So these are the different risk categories. So there is high risk for coronary heart disease or coronary heart disease risk equivalents. There is moderately high risk with 2 or more risk factors that the patient has, about a 10-year risk or about 10 to 20%, or a moderate risk, which is 2 or more risk factors or about 10-year risk less than 10% for the patient. So with high risk, the LDL cholesterol goal is for less than 100 milligrams per deciliter with an optimal goal of less than 70 milligrams per deciliter. They would initiate therapeutic lifestyle changes if the LDL is greater than 100 milligrams per deciliter and consider drug therapy if the LDL is greater than 100 milligrams per deciliter. And they would consider drug options if the LDL is less than 100 milligrams per deciliter. The moderately high risk category, in which the patient has 2 or more risk factors, the LDL cholesterol goal is at less than 130 milligrams per deciliter, and the moderate risk is for the patient has 2 or more risk factors with a 10-year risk, less than 10%, and the LDL cholesterol goal is to be less than 130 milligrams per deciliter. Low risk is less than 1% or 1% risk factor, and the LDL cholesterol goal is to keep it at less than 160 milligrams per deciliter. So what is the difference between good cholesterol and bad cholesterol? So HDL is the good cholesterol, is the healthy cholesterol, and LDL is the unhealthy cholesterol. The HDL builds and maintains cell membranes. It is necessary to manufacture bile. It is necessary to absorb fat and vitamins A, D, E, and K. It insulates nerve fibers. It aids in the production of adrenal gland hormones. And they also, HDL cholesterol aids in the production of sex hormones. LDL, on the other hand, is the bad or unhealthy cholesterol, and it can clog the arteries. It can lead to coronary heart disease, and it can lead to heart attack or stroke, and ultimately lead to death. So, just recently, well, not very recently, but in 2013, the National Cholesterol Educational Program released new cholesterol guidelines, which is the ATP4, which were instituted by the American College of Cardiology and the American Heart Association. The new ATP4 guidelines state that clinical trials have shown that treating a patient to a specific LDL level does not improve the cardiovascular outcome. So lowering the total cholesterol and lifestyle modifications are the main focus for the patient. So it is now very, very important to look not just at the LDL levels, but also at the total cholesterol in the combination with lifestyle changes, such as weight management, improvement of nutrition, and better food intake, and also an increase in physical activity. So total cholesterol and lifestyle modifications are now the main focus for treatment of patients with lipid abnormalities. So how do we measure lipids in the laboratory? Lipids, the main measurement of lipids is by measuring the total cholesterol, which takes into account VLDL plus IDL plus LDL plus HDL. All lipoproteins except for chylomicrons are in the total cholesterol measurements. So the 4 lipoproteins, VLDL, IDL, LDL, and HDL, all have cholesterol esters in their makeup and will be measured by all of the total cholesterol methods in the laboratory. Chylomicrons and VLDLs are measured as triglycerides in the non-fasting specimens, and VLDL is measured as triglycerides in the fasting specimens. And fasting is a specimen in which the patient has not eaten in about 10 to 12 hours. They are, however, allowed to drink water during fasting states. So a commonly or a very common routine test in the laboratory is the lipid profile. The lipid profile includes these following tests that you see here: the total cholesterol, HDL, LDL, triglyceride measurements, the cholesterol HDL ratio, and the LDL to HDL ratio. Most of the nowadays, most of the tests that are being done are enzymatic assays, and the one instrument that you have in the laboratory, especially at Valley, is the Vista laboratory, and the Vista will do an enzymatic measurement of the total cholesterol. And so cholesterol esters are converted into cholesterol and fatty acids by the cholesterol esterase enzyme. Cholesterol and oxygen is converted to the cholest 4-in-3-1 hydrogen peroxide by the cholesterol oxidase enzyme. Then you see the reaction that will lead to a measurement of the total amount, or what you're looking for at the end is a substrate for a common enzymatic color reaction that uses a horseradish peroxidase to couple two colorless chemicals into color compound. The intensity of the resulting color is proportional to the amount of cholesterol that is in the sample, and it can be measured by a spectrophotometer in the laboratory, and the wavelength at which this is measured is usually 500 nanometers. So enzymes and enzymatic reagents have actually improved so much now, so that the instruments can easily identify the amount of total cholesterol that is present in the patient's sample. So HDL is measured in the laboratory by several different methods. It can be measured by using the ultracentrifugation method, also by electrophoresis, by precipitation methods, by high-performance liquid chromatography, or HPLC, and also by homogeneous assays that are actually used in automated analyzers. And this is the reaction, the enzymatic reaction of HDL measurement that is done in the actual chemistry instrument that you have in the laboratory for the measurement of HDL. This is also the LDL measurement. On the Vista, it's also an enzymatic reaction that is read by a spectrophotometer. In measuring LDL, it is important you can also measure LDL by doing the Friedewald equation, which takes into account cholesterol minus triglycerides divided by 5 plus the HDL amount. So that gives you the LDL amount. The only caveat to that is that you cannot use this equation when the patient has a triglyceride value that is greater than 400 milligrams per deciliter. And this is how the triglycerides are measured, again, in the laboratory on the Vista. It's also a measurement of glycerol. And it is done by enzymatic reactions. And that ends your lipid lecture series for your chemistry class. We will go back to the chapter and and really read through all the different sections and answer the study questions so that we can review for the exam. If you have any questions, please let me know. I welcome any questions. Thank you.